The Dartmouth Atlas has been a familiar part of the American health policy landscape since the mid-1990s. The Atlas monitors healthcare utilization and outcomes in 306 hospital referral regions across the United States. I'm Gil Welch, and I'm here to interview my boss for the past 2 decades, Jack Wennberg. And my goal is to communicate Jack's quest to explore the epidemiology of American medical care, how medical practice differs in different geographic regions. It's an intriguing story, one that starts in Vermont in the mid-1960s and is still relevant today as the Dartmouth Atlas continues to monitor what is actually happening to healthcare throughout the United States. Chapter 3, Boston, New Haven. In the 1980s, the medical establishment seems more open to your message, and you have a number of articles in the New England Journal of Medicine. Now, why all the interest all of a sudden?
Well, it's hard to actually say, but I can tell you that a lot of things were happening. For one thing, Health Affairs had picked up on this issue, and John Eigelhart had devoted a special issue in 1982, I think it was, or 83, to this whole question of practice variation.
Yeah.
And that certainly was a breakthrough for us. We got the American Medical Association got very interested. People in Congress got very interested. So there was new focus on it. And the mainstream journals came along and began to publish these articles, which was good for us.
Yeah, it was great. And it was also at this time that you developed the Center for the Evaluative Clinical Sciences.
Right. A little later, but towards the end of the 80s. But that was all part of the build-up to the Clinton Health Plan. We were pretty sure it was going to happen, and we were going to play a pretty important role in it.
And it was just a time where there's more interest in healthcare in general,
right,
and
a little bit like today.
Yeah,
but with not so much dissension.
Okay. Well, in this period, you chose to compare Boston and New Haven, and this choice, I think, was very much a tactical decision. Yep. And I wonder if you'd tell us a little bit about your tactics.
Well, sure. First of all, it was possible to do because we were able to get data, although we had to go especially to New Haven to get it. They allowed us in, so to speak. But the obvious reason was because these two cities are served by America's best hospitals and best medical schools. Harvard, Yale, BU, Tufts are all concentrated in these cities. So we wanted to make sure that if these guys are so good, they must be practicing scientific medicine, and we want to know what scientific medicine is. Well, that's a little bit reverse of what we really did it for, but we were looking for benchmarks.
Right.
And we had learned very early that New Haven was lower than Boston. And so we did these 3 studies.
Okay, and again, this I think it was brilliant. I mean, it was, of course, I focus on the Harvard-Yale comparison, 2 of our most prestigious schools, and asking the question, how might they practice differently? You had the article in the New England Journal. It's called Hospital Use and Mortality Among Medicare Beneficiaries in Boston and New Haven. It appeared in 1989, and I want to share with our viewers the primary results, and these are the comparison of Boston and New Haven utilization and mortality rates per 1,000 Medicare beneficiaries in 1985. In terms of hospital admissions, Boston had 324 admissions per 1,000, while New Haven had 221 admissions per 1,000 for a relative rate of 1.47, meaning that Boston had 47% more admissions than New Haven. Hospital days obviously followed those admissions, 3,813 days per 1,000 in Boston versus 2,268 in New Haven. For a ratio of 1.68 or 68% higher in Boston. Interesting to look at those hospital day numbers. You can see the average length of stay in Boston and New Haven was in each case over 10 days. Hospital charges, almost over 1.7 million per thousand in Boston, less than $1 million in New Haven, so it was 79% higher in Boston. And Jack, I'm going to let you talk about that last line.
Okay, well, the question, of course, is which rate is right? Which rate is associated with better outcomes, and what are the consequences for having low utilization? After all, are services being rationed in New Haven, or are they being overused in Boston? Well, this data tells us we certainly don't see any advantage to living in Boston if your goal is to live longer. Right. Interestingly enough, the comparisons are to me, were quite valid because the demographics of these two places are very, very much similar in terms of age structure, incomes, and adjustments that we made for slight differences.
Right, the poverty rate was the same, the percentage of African American residents was about the same, the median income was about the same.
Yeah, and it basically was a natural experiment, basically. So if there was a huge payoff in spending the extra 80% on healthcare, we would expect mortality rates to be quite lower in Boston.
And in fact, you saw no difference, as you see here, and suggesting that at least this form of medical care, hospital utilization, is not a particularly important determinant of health, but sure is a pretty important determinant of cost.
Absolutely.
You went on to talk to docs in both cities. What did they tell you?
Well, one of the things, of course, I was interested in, and I learned this trick from Archie Cochran. When you go into a hostile territory, don't tell them which area is which, or which outcome is which. So basically, I took the slide that you just showed, or a variation of it, and took off the name Boston and New Haven, and then went and interviewed chiefs of service, rank and file docs in Boston and New Haven, asking them, first of all, do you perceive any difference in practices? And this was a particularly useful question for people who actually practiced it in both communities,
places,
of which there were several. And essentially, no one recognized
any difference.
And they had no idea what their rates were.
Right. They couldn't pick out which column was the which.
And they could not. And I also asked the rationing question, do you feel like you're hurting people because you don't have enough resources? And we saw no relationship between what was being done and answers to that question.
Wow. And you often refer to the decision to hospitalize using a conveyor belt analogy.
Right.
Can you share that with us?
Well, I can try.
Yeah, all right. Well, give it your best shot.
So basically, imagine that a physician is responsible for the admission decisions to the hospital. And to sort of simulate this, imagine a conveyor belt that moves along and has on it an assortment of gray, white, and black balls. And his job is essentially to decide who gets admitted to the hospital or put on the shelf, which is above the conveyor belt, which is of a different length in Boston than it is in New Haven because Boston has many more beds.
Right.
So along comes the black ball, and everybody picks the black ball up and puts it on the shelf, no matter where they are.
Right.
And fortunately, or not unfortunately, but in fact, there's very few black balls relative to the gray balls, which is where all the decision has to be focused on.
Right.
So the black balls take up about 20% of the shelves in Boston, New Haven, maybe less than New Haven.
Right.
So the job now is to admit the gray balls.
Right.
Now these people are all sick. You know, they're not as if they were just completely well.
Right.
So picking up the gray balls and putting on the shelf, and in Boston, pretty soon the shelf is full. I'm sorry, in New Haven, very soon the shelf is full. And they start falling off.
But the Boston, there's a lot more room.
And so they can put a lot more people and continuously do so, and that's what happens. But behind all this is the interpretation that we put to this, that capacity exercises a subliminal effect on doctor decision making, neither recognized by the actors themselves in terms of capacity issues or in terms of the slight differences in judgment about who's sick enough to get in the hospital.
Right, and just highlights all this discretionary admissions based on these gray balls that maybe would go in, maybe would not.
And we spent a lot of time studying the nature of those discretionary gray balls.
Well, the choice of Boston and New Haven was tactical. You wanted to show how different medical practice could be in two cities with the nation's most prestigious medical schools. You showed that the high utilization in Boston wasn't driven by a different theory about what was good medical care, but rather simply having more hospital beds. We now know that to be a generic finding, as we'll see in our next episode as we go nationwide.